Well, hello, everybody, and thank you so much for joining us today for our panel discussion, IT and Informatics, the essential partnership to manage the next wave of clinical mobility. My name is Adam Mahmood, and I'm the Senior Product Marketing Manager of Healthcare at Jamf. And I'm so excited to lead this discussion here today with some of our amazing customers. Now, if you aren't familiar with Jamf Healthcare, we focus on a number of different innovative use cases of Apple technology to push forward the delivery of care. Now, in some cases, this may be iPad in the hands of a patient or an Apple TV used for patient experience. In other cases, this might be an iPhone or an iPad used to deliver care by the care team. But whatever it is, we're here to help. And most importantly, we're so excited to share how our customers are leading what's possible in this industry. And with that, I'd love to set the stage and share that these two organizations today have a robust a robust set of experiences driving forward Apple. First, UC San Diego Health, who joined the Jamf family many years ago and has been leading efforts around patient experience and more. And second, Geisinger Health, a long tenured Apple institution with over 11,000 mobile devices in its fleet. To tell you more, I'd love to bring in the people that drive forward these initiatives, first from UC San Diego Health. Eric?
Thanks, Adam. I'm Eric Boyd. I manage our Apple infrastructure here at UC San Diego Health and at Health Sciences. I am our Apple SME and work on all things infrastructure. Brittany?
I'm Brittany Partridge. I'm our virtual care technology lead here at UC San Diego Health. I work a lot with the different Apple deployments as they support our telemedicine. Kyle?
My name is Kyle Ficklin Battaloni. I help manage our iOS devices as well as our Epic mobile applications.
Thank you so much, UC San Diego Health team. We are honored to have you with us today. Now, from Geisinger, we had two individuals planned to be on our panel. But unfortunately, I'll share that James, one of the IT program directors, was not able to join us due to some personal reasons. That said, we wanted to preserve his presence as a member of this panel discussion, given that its context is all about the partnership between IT and informatics. So with that, I'd love to tee it up for you, Jana.
Thank you. Hi, my name is Jana Cass, and I'm a nurse informatician for Geisinger's Northeast region, which includes 2 level 2 traumas in a small community hospital. I report directly to the CNO and serve primarily as the technology subject matter expert for those to connect the clinical, to connect the dots between our clinical end users. That includes nursing, providers, infection control, guest services. My role is unique at Geisinger in that I report to the regional CNO, but I do have system-wide coverage as well as initiatives that will impact our entire system. Thank you.
Wonderful. Now, we got a brief look into our introductions of each panelist to start, but to set the stage for the rest of what we'll dig into today, we'll get a brief background on the Apple deployments in each environment. Now, these stories are long in the tooth with Jamf. So although we'll just scratch the surface of the history today, know that we can refer you out to some more information as well. Most importantly, we'll dig into what's happened over the last year and what's been driving forward change for new mobile experiences. Behind the need for change, of course, is the need to implement. And so we'll, of course, dig into how these IT organizations had rapidly designed, developed, and deployed new solutions. And we'll close out today with how all of this sets us up for the years ahead and how mobility strategies need to evolve given these pressing needs from the clinical frontline. So to dive right in, maybe we'll just briefly go around any other details you'd like to share from the UC San Diego side, either about yourselves or about your team and kind of your purpose within the organization, expanding on what you already shared. Eric, maybe I'll tee to you first.
Well, let's see. I think a lot of folks know about our bedside iPad implementation, and certainly we've done enough previous JNUC sessions that people can review on that. But I would love to share that, we're just looking for ways to take Apple products and implement them in a ways that improves the experience for our patients and our staff, and that really is a big motivator to push the envelope and try and find new solutions and new innovations.
I love it. I love it. Kyle or Britt, any other thoughts from you? Maybe about yourselves, or again, your purpose, your team's purpose within the organization?
Yeah, I mean, I like what Jana said about being the bridge between clinical and technical. My background is in informatics. This is actually the first role where I don't have an official informatics title. And I think our particular team, Kyle, Eric, really work hard to bridge that gap. We go onto the sites a lot and make sure that the implementations that we're putting in for the iOS devices are really supporting the clinical teams in ways that we hope they would.
I love it. Bridging the gap. That's such an important theme. Go ahead, Kyle. Sorry.
To kind of build off that, my background is definitely more technical than clinical. So when jumping into this role, it was quite the eye-opener. But luckily, with both of our different skill sets, we're able to, like Brittany and Jana said, bridge that gap.
Jana, any other thoughts from you?
My partnership with James is a clear indication of the need for the multidisciplinary team, So my background is in nursing, and it's these partnerships with multidisciplinary teams like, they've just shared as well, that really help drive the need and the voice of what the teams need when working on the front lines. So absolutely, I'm happy to share. We utilize a lot of Apple products, and making sure that they work for the clinicians is what it's all about, and patients as well.
Absolutely. I love it. Now, with that, maybe that's a good pivot to, again, just a quick refresher of what the state of the state, so to speak, is from an Apple mobile footprint. UCSD team, would one of you feel free to just give us a quick overview of what the landscape is today?
Yeah, sure, Adam. Thanks. We have roughly 800 bedside iPads, 250 Apple TVs for the bedside, and then we have roughly 800, and that's growing nearly daily. We're slowly deploying out to new departments almost every week, it feels like, for our clinical calling devices. We also have, a large footprint of one-to-one devices for our staff. And then obviously we have devices that are in research and in clinical trials, as well as one-to-one devices for our students. So we try to cover all of the bases.
Amazing. And I know that, again, we can save the long version of it, but what was some of the initial touch points of Apple in your environment? Was it those bedside iPads, or is it more the student one-to-one many, many years prior?
I think we've always just had Apple devices. We started with, we brought Jamf in 2013 to manage those devices that we already had, and that's just encouraged us and given us the ability to grow that deployment further, because we're with the management and being able to prove security and compliance on those devices. It's made it a lot more accessible to use those devices. The comfort level with those with all the different products has been a lot higher, and we're able to make our information security teams and our compliance teams and the folks using those devices happy with giving them the features they need without putting anybody at risk with data leakage and overexposure.
Super cool. Jana, from your end, tell us a little bit about the state at Geisinger. I already gave away, I suppose I spilled the beans earlier when I said over 11,000 mobile devices, but care to expand a bit?
Yeah, absolutely. So I know that Geisinger has been using Apple products for quite some time now, and that has definitely helped us in today's environment. iPhones, iPads, Apple TV, you name it. And so we continue to deploy and implement different technologies, some in new spaces and some improvements in the already existing technologies as well.
Very cool. And following the story over the years, it's been interesting to hear, even ahead of the pandemic, primarily from James and others on the IT side, of course, the ones that we typically work with most frequently from Jamf, a mobile device management solution, but hearing those needs of new use cases or iterations of use cases or layered use cases for a device that Geisinger has pushed. So I know we'll get into this a little bit more, but it's been really interesting to see how you've had that foundation to adapt when those needs come from the front line. And maybe coming back to you and Britt and Kyle's broader point here of bridging that gap, right? And knowing how to communicate those needs back to how IT can deliver. So I got to make sure I'm using the right device here to transition our slides forward. But moving into kind of the heart of what we're here to discuss today. It's not just about that legacy of what you've had with your Apple devices, but it's really what's changed over the last year is the heart of what we'd want to unpack. So, Britt, maybe I'll turn to you first. What's the last year of mobile change look like at UC San Diego Health from a telehealth and virtual care perspective?
Sure. So, what's kind of been unique about this year is we're coming off of a year of massive, rapid change for COVID. And now we're looking at, okay, how do we stabilize that while still addressing all the COVID needs and moving forward? And so, a lot of our change has been driven to optimize systems that we rapidly put in place during COVID. During COVID, like we all know, it was just kind of slam it in there so everyone can do their jobs. And now it's kind of going back to how can we optimize what we've already put in? How can we make it easier for our clinicians and our patients? And for us, since everyone is still mostly working remote, even some of the providers are remote if they're doing care that way, having Jamf available to push out things to our different devices rather than needing to collect all the devices, touch all the devices for all these different changes has made a big difference. So mostly in my world, it's been optimizing systems that we've already had in place, especially in telehealth, doing things like context aware linking or getting interpreters where the patients need them, and just being able to push it out from a centralized location has been great.
Very cool. Maybe just to pull on it a little bit more. You mentioned obviously all the quick innovative things that were put out in response to COVID, and now this kind of optimization that's being pulled behind it. Like, just to restate, like, what are some of those things that you guys put out? I know there was a number of different point-to-point telehealth solutions that leveraged an Apple device, either by the provider or the patient. Any quick color on that for the audience?
Yeah, so we were doing deep integration previously, which means we stay inside of the Epic applications when we were providing telehealth. And to get a more stable system, we moved to what's called context-aware linking, which links out to a browser when you're doing telehealth. So we needed to make sure that was configured appropriately in all our devices. And then also making sure that interpreters were always available. We had them integrated in our first iteration, but then making sure that the nurses had them available when they need them. They were also in telemedicine, making sure they were available for our inpatient telemedicine. Just kind of an all around, making sure we grab all the gaps that we had before.
Super cool. And then Eric, to maybe keep me honest here, but with Britt's last point of making sure that was available for inpatient telemedicine, that would mean that those iPads at the bedside that have the virtual visits type workflow to connect with a provider, the Interpretive Services link is available in that experience as well, correct?
Well, we actually have a few different solutions for our inpatients. We wanted to make sure that we had the Jamf virtual visits available so that multiple providers could actually meet with the patient at the same time. And that's, we don't want the patient having to decide which of the two doctors that they want to talk to is the one. It's not a patient call. So Jamf virtual visits made that really easy for us to deploy, and then there is no need for the patient to have that decision to be made. But yeah, so for the most part, I think what we're trying to accomplish is by by deploying this new solution is to make a cleaner and more streamlined solution for our staff to reach out to our patients that are remote, and then making that a cleaner experience, because right now there's a lot of complexity and a lot of folks trying to adjust to this new model. And I think Kyle and Brittany can talk to this more. I think we've seen a really high success rate and a sustained rate of those video visits and virtual visits continuing. So I think that do anything that we can do to make that more streamlined, more resilient, and more reliable is definitely helping everyone involved.
Super cool. Kyle, any additional color or thoughts from your end, or different initiatives or projects to comment on?
Yeah, I mean, we were implementing tablets and iPhones, as Eric and Britt mentioned earlier, throughout this whole pandemic, and finding new use cases for them. One of them being the switch to surgical e-consents using iPads for patients to sign documents and actually read the consents that they're signing, which is a huge win for both patients and providers, as they're able to see and go through the details of the consent form line by line, but then it also automatically files into our EHR, which is huge. So then no one has to scan in any documents or transpose anything. And it also limits contact with unnecessary devices like pens and paper and lots of touching. Just wipe down the iPad in between sessions and call it good.
I love it.
And
I feel like,
throw-
go ahead, Jana.
Oh.
Or Britt, sorry, whoever was jumping in there, apologies.
That's Brett. I was going to throw one more thing out there. So one thing that we've been doing over the last year a lot is, vaccination situations. We have superstations and things like that. But as we moved to a bigger footprint of vaccinations, we needed devices that we could rapidly use for all of our nurses that were running around. And when we initially rolled out the WOWs with the computers on wheels, that was, hard. All of us can attest to trying to roll them over power lines. We would always get stuck like trying to get them going. And so we finally put it on the iPhones for documentation, and Kyle was very important in that rollout. And I would just say that was a huge win, because I got stuck so many times, and so did the rest of the staff with the WOWs.
Yeah, the WOW wheels weren't really intended for parking lots.
Yeah.
I love that you bring that example up. There's actually another session during JNUC on that topic in particular, but I think it's so, it's such an interesting story of, the need to rapidly deploy some mass vaccination, right? Who would have thought 2 years ago that this would be a thing that we'd be focusing on? But now it's like unlocking all of these technical capabilities that we have known have been there, but it's now like the price of admission for us to turn them on. Like, Kyle, how long have you probably been talking about e-consents or pitching an idea around that? But, it wasn't until the need for infection control or other things that we needed to look for digital workflows in some cases. So it's just really interesting. And then I think also back to the spirit of this panel, that feedback that you could provide, Brett, from those on the front line of, hey, this isn't working. Like, how am I supposed to wheel this cow through the parking lot? Right? Obvious. But that ability to just quickly communicate that back to those in IT that could think differently and look for another way to approach the problem, I think is so cool. So awesome to hear that iPhone has been part of that experience too. Jana, maybe transitioning over to Geisinger, what else, either similar or different, has been kind of cooking in your world, so to speak?
Absolutely. And so a lot of similarities, and I'll use their example with the iPads and the language line, or, interpretive services to begin. So there were so many different use cases that came to fruition during the pandemic, especially the nuance of having to screen people who are coming through our front doors. So there was significantly restricted visitation, and those visitors who were to come through needed to be screened. So I worked very closely with our director of guest services for the system to have iPads in the hands of these individuals who are working at the front doors. WOWs would have been helpful. I think they had one WOW at each location for, that full Epic screen that they needed. But the iPads were immensely, immensely instrumental. They were able to work through the process, figure out who we've designated as the visitor, etc. And so we also handed them iPhones because sometimes iPads were in use. You had a line queuing and you needed to move rapidly, but you needed to have a conversation in a more private area with somebody who needed interpretive services. So the iPhones we were able to deploy, and I partnered very closely with James and some other people in interpretive services and patient experience. So I'm glad that they were able to bring that up because that definitely highlighted a lot of what we worked on quickly. and then we talk about virtual visits. So initially we had iPads at some of the hospital, some of the units, etc., for patients to be able to talk to their loved ones, right? So there was restricted visitation, and it was really, really important for them to connect for their health, for their emotional state, and really, you know, because their loved one couldn't come in and would have done anything to be at their bedside. So, we worked with FaceTime, Apple IDs. We used virtual visits, which was phenomenal, very quick and able to connect, at a couple of clicks, which was great. And then I also want to talk about how the iPads on stands were really helpful out of the box. So during code situations, which is when a patient is needing some emergency treatment, we had to keep doors shut and over HVAC systems and loud, negative pressure rooms. And so what the teams used was an iPad in the room and an iPad outside of the room, and they were able to use that as a communication method so that they didn't have to keep opening up the room and potentially exposing other people in the emergency department. So really groundbreaking use cases across the board. And, I'm just here to talk about a few of them, and I'd love to share as many as I can, but we'll save it.
It's really cool. It's near and dear to my heart. I know Eric and a few others know. My late father, was a pioneer in home telemedicine and telehealth 30 years ago. And so, as I said earlier, to see some of the technical capabilities that have been long in the tooth now given price of admission to truly make an impact, it's so meaningful. And something as simple as just that, an iPad on either side of a wall, but to connect people at a safe distance rather, is so cool. And yes, you both have mentioned Jamf's virtual visits. We quickly reacted, and Eric worked with you and the team at UC San Diego to develop this workflow, leveraging either Zoom in UC San Diego's case or Microsoft Teams in Geisinger's case. But frankly, it's so much bigger than that. We don't care, frankly, if it's our telehealth workflow leveraging those video conferencing providers, or your dedicated, integrated telehealth solutions to Epic, Britt, to your point, or third-party telehealth solutions that run on Apple devices. We just want to ensure that we can help manage them and lay down the foundation so that users can get the experience they need. So thank you so much for sharing all this. I think it's really, really insightful information, especially for other organizations that are not as advanced on their journey into mobile. So looking at our time, would love to spend a few quick minutes on the how component of this. Eric, maybe I'll really look to you primarily. When you think about this from, and Kyle and whomever would like to chime in, but when you think about making good on these rapid design and deployment kind of needs based on what we just spoke about, what was your approach? How did you reach the results you needed? Thoughts?
Yeah, so I think we had a really great team in our ability to sit down and figure out with Brittany and Kyle and the rest of our team to see what was actually needed and then how we could go about and rapidly meet those needs. What configurations could we rapidly deploy? What configurations were we going to need some additional work with from our networking teams, et cetera? And then where did we have the abilities to actually get devices moved around to and from? So, that's why I think it's really important to have a diverse group and a lot of interconnected communications between the different teams to be able to pull and leverage all of the different resources throughout the organization. So I think where we were really successful was in rapidly redeploying devices that weren't being utilized any longer. For example, when we were shutting down some of our unnecessary or non-urgent procedures, being able to move devices from those locations to rapidly redeploy them to be telehealth devices, while we then figured out what our permanent telehealth solution was going to be. Looking at those different approaches and being able to redeploy devices, that was really easy for us to do with Jamf because it was just recategorizing the device and wiping it and then having it set up in the process of it being physically moved. So those workflows were really easy in terms of the technical piece. We just wanted to make sure that we weren't overstressing our other teams in getting those devices redeployed, and also not needing to purchase devices that weren't going to be necessary after this process. Kyle, do you want to touch more on this? Because obviously you were a huge help to me and the rest of our team on this redeployment process.
Sure, I'll briefly touch on that. Thank you, Eric. Appreciate it. When we were doing our video visits initially, for a provider to perform said video visit, it had to be done on an iOS device, i.e. iPhone, iPad. And so we couldn't use a computer at the time. So when we were mass deploying these iPads and iPhones just to get providers to do video visits, that was a all hands on deck situation. And luckily, besides driving to different sites, that technology wasn't the bottleneck there. We were able to, as Eric said, mass reconfigure and deploy all of these iOS devices just so that we can do what matters most, and that's helping the patient. Getting a provider a tablet so they can do that virtual care.
Love it. I know that the theme of rapid redeployment is something James and I spoke about last March, right at the beginning of all of this. I think HIMSS had just been canceled, and we were doing a webinar together. And just like Eric had mentioned, he said, we were just gearing up to expand our bedside iPad deployment, and we pumped the brakes. And we literally, in 1 week's time, flipped is kind of how he phrased it, but flipped those into telehealth providers, provider telehealth iPads to work from home with. So maybe from the informatics side, was that a smooth transition? Did you see any pain points, gotchas, or commentary in and of itself of rapid redeployment of those devices? Any thoughts?
Absolutely. I would say we did a good job. We did a great job of getting them to where they needed to be rapidly. And so time was of the essence. So we had telehealth. We also were able to utilize some of the telehealth platform in an EICU format as well. So when you think of having patients outside of units or beds specific, so outside of the ICU proper, we had to prepare for sicker patients being in places where they might not normally have been before. So IT working to hear the needs really helped get those telehealth resources, EICU resources to where they needed to be. And so then you would have a critical care provider who is able to provide, help and assistance and oversight in a bigger footprint. And then you talk about, the telehealth as well as on offsite locations as well. So that definitely touched on the inpatient and the outpatient setting. I think the real nuts and bolts of it all is really being able to problem solve and figure it out from a multidisciplinary perspective. I know Eric mentioned about, working with networking and just the different teams, because it takes a village, especially when you're moving quickly.
That might be the perfect
all
pivot point.
really assisted.
Sorry, go ahead. Finish your last point there. I cut you off. Apologies.
No, that's okay. That was it.
Okay, wonderful. I think that's the perfect point there of the multidisciplinary approach and how critical it is. And frankly, what I've seen working with yourselves and many other clients, but to see how you've been able to meet the need and find success, I think that certainly is at the heart of it. But maybe with that as its backbone, and again, with all this change, would love any quick color from either of your organizations of what's ahead. Have there been fundamental changes in now how you look to solve those problems moving forward, given what we've experienced over the last year? San Diego team, maybe I'll look to you first.
Brittany, do you want to call out some of our... Oh, go ahead, Kyle. Sorry.
Oh, no, Britt, do you have anything?
I mean, for me, it's mostly just focusing on new opportunities for telemedicine. And then also, I just wanted to call it, so Jana was talking about the iPads on wheels or iPads on stands. And I think those are here to stay because people keep finding new and fun ways to implement that. We just had a magnet survey, and our assessors went around as iPad on stands with old school nursing hats on the iPads because they couldn't be here in person. So I think that is going to be something that we're going to see a lot more of.
Very cool.
Yeah, I want to just touch on the fact that... Go ahead, Kyle. Sorry. Keep stepping on.
Oh, no, you're good, bud. No, I mean, Britt nailed it. Like we're finding new, fun, innovative ways to do this. And when we come up with solutions now, now we have to focus on a mobile aspect of it being the standard as well, instead of just focusing on, traditional desktop, laptop models. We can now incorporate iOS into all of that.
I love that. That's certainly what we've heard from a few others.
Yeah, the point I wanted to just touch on quickly is that we're not having to go out and find ways for the technology to be used. Our staff are coming up with wonderful ideas and wonderful suggestions on ways that they can utilize the devices to make their lives easier. And then we work with them to see what is the best way to implement that and make it sustainable in the organization. So I wanted to just kind of give a thanks to Jamp for giving us that flexibility to redeploy and innovate and iterate on these devices and making this a sustainable solution.
Love it. I love it so much. Thank you. Jana, close us out here. What are your thoughts of what the next year or beyond looks like from Geisinger?
Some of these processes and workflows and technologies are here to stay. We've implemented virtual rounding and virtual patient discharge appointments so that if your loved one can't be here for when we discuss the plan for today, we can call you into it. And there's a lot of reasons why somebody wouldn't be able to come and be there in the 10, 15 minutes when the provider, the nurse, the care manager all come together. So that is here to stay. Maybe your daughter lives in New York, or maybe there's just some reason they couldn't make it, and here we are utilizing the iPad with a video and pulling them in. Even so I talked about that patient virtual discharge appointment, which has been really wonderful because we're connecting sometimes their primary care provider, we're connecting case manager, pharmacy, and really hoping to get all of the disciplinaries that will help to see this patient remain free, of being admitted to the hospital, reduce those readmissions. So yes, it started under the COVID pandemic guise or, world, but I'm happy to say that it was needed probably before, and now we will definitely be utilizing them in the future as well.
I couldn't have said it any better myself. It's those tools, technologies, and processes are here to stay. And Kyle, as you said, it's now given price of admission for mobile to be the standard and not to be the secondary path, but perhaps the best path for users and for outcomes. So with that, thank you all so much for your participation. As I just advance forward here, a quick couple last looks at both of your organizations. Who wouldn't want to come stay at UC San Diego Health at Jacobs and consume this experience as a patient, or have this type of tremendous care from Geisinger Health? And frankly, it's not just because of the Apple devices in both pictures, but it's because of the great teams that are behind those experiences at both organizations. So with that, thank you all for listening. I hope you have a great rest of your JNUC. And panelists, thank you.